treatment.
So, hi, I'm Sravan Panuganti. Thank you for that wonderful introduction. So when I was assigned this topic, I actually kind of struggled with it because we know that BPH and erectile dysfunction correlate significantly, and I'm going to sound like a broken record to what my colleagues have already said today. But the why, I mean, I don't think, and I couldn't find any studies about that, and it's, why did my son wake me up at 6 o'clock this morning to go swimming? Because he likes it and it's fun. So those of you who've had sex, it's fun and guys like it. So I mean, that's the answer, right? So let's kind of get into some nitty gritty of this stuff. I'm a consultant for Prosec Biorobotics who makes aquablation. So my objectives here is to discuss the prevalence of desire to maintain sexual function in BPH surgery, discuss the types of BPH surgery available in the US, resective versus non-resective, and their role in sexual dysfunction, or sexual function rather, and discuss ejaculatory sparing techniques in resective BPH surgery. So, as we've talked about many times today, a lot of our men over the age of 60, over half of them will have BPH, resulting in lower urinary tract symptoms, and that correlation goes up with age. There's an association between sexual dysfunction and the effects of BPH have been established, and we have demonstrated, and we know this, that sexual problems such as erectile dysfunction and ejaculatory disorders were strongly related to patient age and the severity of their LUTS. And sexual activity remains an essential component of overall quality of life in most men, regardless of their age. So BPH surgery can negatively impact sexual desire, arousal, satisfaction with negative psychosocial impact. Sexual dysfunction can occur with thermal damage when the neurovascular bundles are dissected or damaged. Over 90+% of men do care about erectile and ejaculatory dysfunction regardless of their age, and we've already talked about this. This is a little bit of a busy slide, but it shows about the rates of ejaculatory dysfunction, retrograde ejaculation, and painful ejaculation with various BPH technologies, and with those instances being higher with TURP and HOLEP and green lights. So when we talk about treatment options, we talk about resective and non-resective options. So non-resective is when prostate tissue is not removed during the procedure. Those most common ones here in the United States are UroLift and Resume. Efficacy, they don't have as great efficacy on symptoms relief as some of the more resective technologies, and they don't have great long-term durability. However, they're pretty safe with minimal irreversible side effects. And the procedure, you're kind of limited to intraoperative visualization based on your cystoscopic view, and you obviously have size and shape limitations. When we talk about resective technologies, we talk about TURP, HOLEP, green lights, enucleations, aquablation, simples, and these have sustained high impact on symptom relief. But with safety, a lot of these have high rates of irreversible complications like incontinence and ejaculatory dysfunction and erectile dysfunction, not so much with aquablation. But until aquablation came around, you were also limited on the cystoscopic view, and you had size and shape limitations based on for TURP and green lights as well. And also there was some operator operator error or, surgeon kind of variations that would dictate how well these techniques would work on certain patients. And as we know, prostates come in all shapes and sizes, and, like Dr. Guy said, size does matter. Oop, I'll go back here. And, with the smaller prostates, the non-resective treatment options had some symptom relief, but they did prioritize sexual function and continence preservation. And 76% of men feel that BPH surgery requires a trade-off between safety and efficacy. And we know that 83% of men are not willing to sacrifice sexual function for symptom relief. And until recently, we didn't really have anything that bridged the gap. With very large prostates, we would do simples and enucleations and tell men they would kind of have to live with their ejaculatory dysfunction. And then with small prostates, you had Resume and UroLift, but also telling patients that this is going to only last a few years and you're going to need something else down the road. And there was a really unmet clinical need of something that really bridged the gap and was essentially size independent to treat all prostate sizes for the most part without sacrificing a lot of the sexual side effects until aquablation came along. So to get into kind of ejaculatory sparing techniques that we talked about previously, there's a technique that describes performing conventional TURP, but starting about half a centimeter away from the bladder neck. Studies found that significantly lower rates of retrograde ejaculation and incontinence compared to standard TURP without significant difference in IPSS scores or complications. And also the use of bipolar energy was used in this trial. Manassa et al. Also described a technique where a strip of mucosa was left from the viru all the way to the bladder neck with similar findings with preservation of sexual dysfunction compared to standard TURP. There was also viru hood sparing resection, where a ejaculatory hood is basically created to kind of act like a backboard to allow ejaculation to expel per urethra. That's basically the anterior channel that UroLift and Resume do, and that what aquablation provides as well, because now you're resecting in more of a horizontal fashion instead of a diagonal fashion compared to standard TURP that we were all trained with. Integrated ejaculation was reported in 85% compared to 31% using standard vaporization in terms of green light, and similar techniques are starting to be adopted by whole-up surgeons in patients who wish to spare ejaculatory function as well. And this is the same diagram that we looked at previously in a previous presentation, but basically leaving that apical hood of tissue that will come together during the ejaculation to make sure that ejaculate comes out per urethra instead of back into the bladder. So in conclusion, the preservation of sexual function is likely more prevalent than we originally thought. Patients' desire to maintain sexual function should be a part of every discussion regarding BPH surgery, and there are many types of treatment options available to treat a wide array of patients and prostate sizes while respecting their wishes to maintain their quality of life desires. Thank you very much.